Ladies and gentlemen, thank you very much for joining us on this evening, the Jamaican Diaspora Health webinar. And we have a beautiful guests lined up tonight talking about rehabilitation. We're talking to allied health professionals in the art of rehabilitation. I'm so happy to be surrounded by great leaders in their fields respectively. So we have, in no order here, but we have Marie Adams, who'll be talking to us this evening. We have Dr. Patricia Smith, who'll be talking to us also. Dr. Milas Ruth Mwanza. And my co-host this evening is Dr. Melrose Stewart. And Melrose, I'd like to hand over to you to just get us going this evening. First of all, before I hand over to you, I just want to say thank you very much to Jamaican Diaspora for putting on this event for us and allowing us to sort of continue these discussions around health. And I'm so happy that we'll be talking about rehabilitation. Please, Mel, just please kick us off. Oh, you're on mute, Mel. Because you're on mute, I think there's one more thing I needed to say, which was thank you very much for Victoria Mutual for sponsoring this event also. There you go. Over to you, Mel. Just take yourself off mute. Yes. Right, that's it, yeah.
Is that better? Okay.
That's perfect, yeah.
Much. It's our pleasure, my pleasure. It's probably a first, you know, that we're going to be talking about rehabilitation. And I'm really looking forward to the evening, because I don't think we've ever had a group of people like this to present on the topics that we're going to do tonight. So the focus of the webinar tonight is that we're going to highlight the role of rehabilitation specialists with particular insight into African Caribbean community. So we're going to have a focus on that. We're going to identify factors which might challenge access to rehabilitation. And we hope to offer some guidance in how people might access rehabilitation, and also to outline some self-help strategies. So this is all about you looking after yourself, being guided, and where to find information. So we'd encourage you to get in touch with us. You'll get the contact details later, and ask as many questions as you want to. We're here to give as much help as we can. And so just as by way of background, really, it's just to say rehabilitation is a team effort. And the plan today was to have different allied health professionals join us, but unfortunately, for one reason or another, we're left with the physios today. But that's no bad thing. We think we've got a good part to play, and a very important part to play. But of course, normally there'd be speech therapists, dietitians, there are so many allied health professionals that you're probably not aware of. But tonight, as I said, we've got the physios. But by all means, ask questions about the other specialists if you wish to. Now, we know the quality of life depends on, you know, looking after acute injury and short-term injury, but many of us are left with long-term injuries and long-term illnesses that needs maintenance and good health and good support. And this is where physio steps in. So I'm not going to spend too much longer talking about this. I'm going to hand over to each of these specialists for them to say very briefly who they are and what they do, just to give their title. And then I'm going to introduce our speakers in turn. So I'm going to start off first with Dr. Patricia Smith. Tell us a little bit about yourself.
Oh, hi. Thanks very much, Mel. Thanks for that introduction. My name is Patricia Smith. I'm a physiotherapist. I am a senior lecturer at the University of East London, and I also do a lot of community work in Newham. And this is just around helping people to manage their long-term conditions, such as diabetes, musculoskeletal problems, arthritis, etc. And yeah, that's me basically.
Yeah, that's wonderful. Now, Milas has joined us. Milas, you need to unmute and just tell us very briefly about who you are, what you do.
My name is Milas Mwanza. I'm also a neurophysiotherapist, and I was born in Zambia. I'm a Zambian, and my role is actually physiotherapy, and I look at neurological conditions, be it the brain, be it the spine, be it any neurological condition. But on top of that, I look at the whole aspect of a human being with multi-complex problems, pathologies. It's not only neuro. I look at the whole picture of a person. And apart from the acute sector, I also look at the community sector as well. So doing home visits and running a clinic, and also participating in the vibrant activity of the exercise group in the community. And I think I will say a little bit more in my presentation.
Excellent.
To ask me questions.
And last but by no means least, we've got Marie. Marie, tell us a little bit about yourself.
Hi, my name's Marie Adams. I live in Birmingham. I have spent a long time in neurorehabilitation, specialising in neuro rehab. Started off in the acute setting, worked in the community for a very long time, so could see different aspects of rehabilitation in different settings. And now I work for a large private sector organisation as a clinical services manager, managing a multidisciplinary team of speech and language therapists, as you were saying before, Mal, OTs, physios, dietetics. And so we have the full multidisciplinary team available as a resource. And so I'm very privileged to have a really great team as well. I really enjoy rehabilitation. The smallest things that you can do for our patients makes the biggest difference to them, and the impact that it has is phenomenal.
Fantastic. Oh, I'm so proud of my colleagues. And of course, you can see I'm passionate about physiotherapy, because I think, if anybody moves, no matter how little or how adept they are, the quality of movement is what physiotherapists are addressing all the time, that quality of life. So I'm going to ask Dr. Patricia Smith to kick off with her presentation. And if you have questions, as I say, please, direct them to us later. And I know that a lot of people don't know much about physiotherapy, and some of the things we say might be new to you. So please do not hesitate to get in touch with us. Okay, so over to you, Patricia. Thank you very much.
All right, I am trying to share my screen. I hope you can all see my slides.
Yep, all working.
Okay, great. Well, let me just go back. Oh, sorry. Let me start again. Just go to the first slide. All right, so, okay. Right, so thanks very much for the honor and the pleasure of being able to speak with you all today about rehabilitation in the African Caribbean community, the Jamaican Diaspora. When we talk about rehabilitation, it's a very big topic that cannot possibly be covered in an hour. But my colleagues and I will give an overview on some of the main ideas about rehabilitation from the perspective of allied health professionals. And we'll give this perspective both professionally and also personally. Now, I'll be covering the question of what is rehabilitation, how it works, the purpose and role of rehab in the African Caribbean community, and why it's important. So there will be an educational aspect to my presentation, so please do bear with me, okay? So now I couldn't help putting up this slide because it reminded me so much of home, back in the Caribbean, where I grew up in Jamaica. And a lot of you will know, I didn't say this in my presentation, in my introduction earlier, but I trained at the School of Physical Therapy in Jamaica. And I came to London, did my postgraduate work here. And when I came here, I worked in the NHS for a number of years, starting off in neuro rehab and some musculoskeletal conditions, and then went into community rehab. And when I went to the community, I never turned back. I just enjoyed working in the community. I know, Marie, I can see you nodding your head because you understand that how it pulls you. But when you talk about rehabilitation and rehabilitation in the community, it is so, so exciting, and you learn so much, and no 2 days are the same. So I just show you this picture here of Jamaica. The hills are in some parts of Jamaica. And when I worked there, I worked a lot with patients who were in rural communities. And a lot of these patients had stroke. And I had to work in terms of rehab helping them to get back to their full potential in their own environment. And a lot of the environment is kind of rocky and hilly and so forth. And it was really quite a challenge, but a pleasant and enjoyable challenge to help these patients get back to their full potential. And that's what rehabilitation is all about. And for some of you who might know what it's like growing up in the Caribbean, for some of our elders and some of you who might have visited Jamaica or the Caribbean or in parts of Africa, you will be used to the sun, enjoying the fresh air and fresh fruits and vegetables and all the things that you do on the countryside. And rehabilitation was, there was a naturalness about rehabilitation, which, you know, a lot of times when we come in other societies and other communities, we are not able to capture that, you know, and therefore, you know, it's great, it's very good that we've put this, this talk on so that we can sort of set the background how diasporan African Caribbean people can understand rehabilitation and some of the challenges of rehabilitation in this present society. So I thought that would cheer you up a bit. Okay, so rehabilitation is really an umbrella term to describe the process of returning the patient to their original condition of state, their original state of health and well-being, or as near as possible, you know. It can be, for example, defined as restoring the condition of good health. The World Health Organization in 2011 defined rehabilitation as a set of interventions which are designed to optimize function and reduce the disability in an individual with a health condition, and for them to be able to interact with their environment. Now, the term environment can be quite wide. We can talk about social environment, you can talk about physical environment, your mental environment. You know, there's so much you can talk about. And I'm going to leave that to my colleague, Miles, who's going to go into a little bit more detail on that. But also the Chartered Society of Physiotherapy in 2021 also defined rehabilitation about enabling and supporting individuals to recover or adjust to achieve full potential and to lead as full and active life as possible. And that's an important thing. The physiotherapist plays a very important role in helping people to regain their functional activity, to be able to attain a quality of life that they had pre-injury. I will use one example of an injury such as a stroke to highlight some of these things later on in my presentation. So that's the important thing about when we talk about rehabilitation. So those are two little very simple definitions that I thought I will share with you so that you know that there is an evidence-based practice that supports what we do as physiotherapists. So when we talk about physiotherapy, we're talking about health or health rehab. We're referring to not just physiotherapists. And I'm going to talk a little bit about the other people that are involved. And I'm sure Marie will pick up on that a bit more in her discussion. But you know, when we talk about what is the purpose of physiotherapy, it's to of rehab, is to restore one to normal form and function, someone who has sustained an injury or suffered an injury. So it's not just about the physical impairment that you're trying to help and to restore. That's important. But it's also about the physical and social environment, you know, the things that the person used to be involved with, the things that they enjoy, their family, their friends, and so forth. And from an African Caribbean perspective, it's also important to look at the cultural environment, which is very, very important in rehabilitation. And a lot of times, being able to access rehab services and to know where to go, how to navigate yourself through the NHS, through the health services, and what resources are available out there can be quite challenging for our elders and others in the African Caribbean community. And I'm sure in probably other ethnic groups as well, but we're focusing on African Caribbean people. My colleague Marlis will talk a little bit more about that later on. Okay, so let's talk a little bit about who makes up the team, right? And, you know, rehabilitation, as I said, is a process of returning the patient to an original state of their condition, and as near normal as possible. And as physios, we are very reluctant to use this word normal, and we tend to use it very cautiously, because what is normal for one person may not necessarily be normal for another person. So we prefer to say things like, you know, we're helping the person to restore to the level of normality that they had before their injury, their stroke, or, you know, their hip replacement, or whatever it is that they might have had to go through. And that there are a number of people who are involved in that rehab process. We've got the occupational therapists who look at things to do with activities of daily living, how to perform a task well, how to manage in the home and work and so forth. And then we also have, as I said, the physical therapist. And what we do mainly is around strengthening movement of limbs, you know, desensitizing and sensory function, functional activities and so forth, just to name a few. And of course, we've got the speech and language therapist, who's very much involved in helping the patient who has a chronic condition to relearn certain speech skills. But I won't go into detail on that. And that's just to let you know that rehabilitation is a multidisciplinary, involves a multidisciplinary team, and it's a process. It can take quite a while, and it involves a number of steps, and everybody that's involved in along those steps have a special input to that. So the rehabilitation process is done by a team of health professionals who have detailed knowledge on special processes involved in rehab. And it can be done in hospitals, it can be done in rehab centers where there's a complete team, and there's a lot of communication that takes place between the team members. In physiotherapy, rehabilitation can be done in these centers as well, but sometimes it can be done in private clinics, personal clinics, in community centers, in gyms, and even in people's homes. And that is where a lot of rehab actually does take place, in people's homes. So physiotherapy is one of the allied health professions, and we work at restoring normal movement resulting from either musculoskeletal or neurological disorders. And from the point of view of physiotherapists, especially one that works in the community, rehabilitation, as I said, is not just about physical restoration of muscles, joints, movement, bones, and so forth, but also about mobility, independence, addressing mental, emotional, and psychological issues that may sometimes be associated with health conditions, and especially in the context of the person's own cultural and, I would say, spiritual environment. So when we talk about rehab in physiotherapy, and I'm speaking just as a physiotherapist, it might be the same for others, but as a physiotherapist, we're talking about a holistic approach, a systems approach, and it's not just limited to the biomedical model, because, you know, we get so caught up in the bones and the muscles and so forth that we forget that we're dealing with a person who has a life, a person who has a family, a person who goes to church, a person who likes to garden, and that sort of thing. So we're very person-centered. We look at the environment. And we, you know, in physiotherapy, one of the models that's very popular is the biopsychosocial model of health, right? So let's just look at, say, somebody who's had a stroke. Now, I use stroke because stroke is so common when we look at some of our elders, our African Caribbean elders, our mothers, our aunties, our uncles, our fathers, grandparents, and even some young people, because stroke is not something that just happens in elderly people. It can happen in the young as well. So when we look at something like a stroke is a condition that causes a disability which is usually presented by weakness on one side of the body. Oftentimes it's on the left side, but it can happen on any side. And it occurs when there is loss of blood flow to a part of the brain, even just for a few seconds. And what are some of the signs of stroke? Well, you can see here in this picture, and the NHS has been very good in putting out a lot of information out there in the community about how to recognize a stroke. There's drooping on one side of the face, weakness or paralysis on one side of the body, slurred speech, and sometimes, in some cases, there is loss of consciousness. Now, this is quite traumatic for the person who's experiencing it and for the family who is seeing this. And this is a state of emergency. It's something that means that you need to dial 999 immediately, you see? Now, I'm not going to go into the medical management of a stroke, but focus on the rehab. Rehabilitation begins as soon as possible when somebody who is, say, admitted to hospital with a stroke. The physiotherapists will go in and start doing passive movements, moving the arms and legs so that stiffness and so forth doesn't develop, right? So that's the process. It starts, and we work with other members of the team, as my colleague will tell you a little bit later on. But sometimes accessing rehab can be difficult. Sometimes you don't know who to contact, who to get in touch with. So my colleague will talk about that a little bit, and about the expectations, right? So let's say, for instance, there's somebody who's had a stroke, either yourself or a friend or somebody you know, and you've had a period of time in hospital. Now you're discharged home, your medical condition is stable, but you still have difficulty getting out of bed, transferring onto a chair, going onto the commode or onto the toilet, getting up from standing, from sitting to standing, getting into the bathtub, going upstairs. There's so many things that's difficult for you. And that's where the physiotherapist comes in. The physiotherapist prescribes certain exercises, certain functional activities to strengthen the muscles, to help to stimulate the nerves, and to do certain stretches, which helps to restore you to a near normal function as possible. And the whole purpose is to achieve your goal. What is your goal? You want to go to the shops. You want to play with your children, your grandchildren. You want to cook. You want to be able to hold your spoon. You want to garden. You want to do your housework. You want to do, you want to go back to work. And these are the things that the physiotherapists will bear in mind when we do joint goal setting with our patients. You want to go back to a state of peace of mind and enjoyment of the things that you used to do. And I just want to say that this is very important, the emotional and mental state, because when you have a positive outlook, when you're peaceful, and when you're in a happy and joyous state, regardless of what's happening, then it motivates you and brings you to a point where you're ready to work to achieve the goals that you want in your rehab program. And the physiotherapist is here to help you to improve that, to improve your quality of life, to help you reintegrate into society, into the community, etc. Now, there are other conditions other than stroke where we have this approach. There might be people who have chronic obstructive pulmonary disease, people who have asthma, people who have long-term arthritic problems and mobility problems. The same rehab approach applies as well. We might have different things that we might apply. For instance, somebody with COPD, we have to teach breathing exercises, exercises that improve your lung capacity, lung function, and so forth. And all of it is with the purpose of functional independence. Why is rehab important? Functional independence, a return to as near normal a life as possible, to improve your quality of life. You don't have to be dependent on others, but you can do the things you want to do that gives you enjoyment, that gives you pleasure, and to also be able to help you to redevelop your family relationships and integrate with your family, to visit your friends, to talk to your friends, to get back into your community, to go back to church, to go back to your place of worship, to go to the gym, to do all the things that you enjoy, and to develop your own self-interest and goals. You see, so, you know, when we talk about rehab, we're talking about being able to get you back to a point where you were before. A lot depends on your motivational levels and the input and support of your family, your own spiritual power, and support of your religious group, and your mental and mindset as well. Positive attitude, a happy and joyful disposition, and being at peace in your own mind helps you to restore physically a lot better. So rehabilitation is about your goals, what you want to achieve, what you want to do, and the physiotherapist assists you with that. So I'm going to stop here. This is just a reference for some of what I presented from the Chartered Society of Physiotherapy and also from the World Health Organization. I'm going to stop here, and I'll take questions at the very end, and I'll hand back to Mel and to my colleagues who will develop on this. Thank you very much for listening.
Thank you very much, Patricia. That was incredible. I hear the passion, and if anyone is sitting there thinking, oh my goodness, how do the physios do it? We're all about motivating people to do their best. And Patricia's touched on so many important aspects of rehabilitation. I'm not going to spend too much time on that. We can come back to some of the points she made, but that was wonderful, Patricia. Thank you so much.
Thank you. Thank you.
I'm now going to ask Milas Mwanza to give her presentation. I know she was having a little bit of difficulty earlier getting her screen up, but Milas, are you ready to go?
Yeah, will somebody open up my presentation?
Thank you very much.
Okay. Let me just give me a second, please.
While we're doing that, I mean, thank you so much, Patricia. You've touched so many issues, and obviously you'll brush more on that as we tag along. And just remember, everybody has got the right to rehab. Everybody has got the right to have access to rehab, no matter in what situation you are in, because you are the center and all the others, the professionals are there for you. You are the center. We're looking at you to make sure you maximize your independence, as Patricia has said.
Yes.
Okay. Thank you.
Okay. All right, give me a moment. I'm trying to bring it up.
Fantastic. I think while we wait for the presentation to head up, I'd just like to invite people to post questions, please. We're basically live streaming on Facebook and YouTube. Thank you very much for joining us this evening on this Jamaican Diaspora Unleashing the Potential discussion on rehabilitation, particularly in the Black community. We've heard already, it was great talk there about rehabilitation, and I'm desperate to hear some from the viewers in regards to some questions that we can relay to our panelists. So we should surely be bringing up the presentation for us all to.
We're only touching on perhaps the most common strokes and common conditions. There'll be a lot of people out there who will have conditions who they think, do physios do anything for that? So they can ask those questions as well.
Yeah.
We're ready to go?
I think it's all up now. I'm just going to put in slideshow mode. I hope everybody can see that.
Fantastic. Yeah, we've got a presentation just there.
She put it in a slideshow mode.
Yeah, it's coming up. Okay, there you are.
Okay. Right. As I've introduced myself, my name is Milas, and I have worked in various capacities as a physiotherapist, obviously from the acute setting as a male physiotherapist, basic rotation, and also acute setting, opening up stroke units, and working in the integrated care team with bed-based, and also back to the community. And as my colleague has said, once I looked at the community, I never looked back, because the best place for anybody for rehab is in your own home. It's in your own home. So everywhere else where you've been, it's been a touch base to get you from acute to get over the condition, and so that you can function at home. Next slide, please. Okay, my contents are various contents I've put down, defining rehabilitation, which my colleague has talked a bit, and I'll just touch on maybe one or two. And also, we have moved on from biomedical to psychosocial approach, using the International Classification of Function, ICF, by WHO. And then I'll talk about access and existing channels to rehab. And also I'll touch base on multipathology and COVID-19 restriction to participation. I'll talk about constraints with resource allocation, conclusion and recommendation, and obviously where I've got the references from. Okay, next slide, please. Now, my definition, obviously Patricia's touched base on other definition. Now, the WHO 2011A, it includes a definition as an intervention to improve body function to more comprehensive measures designed to promote inclusion, and that is ICF, which provides a framework that can be used in all aspects of rehabilitation. ICF has been adopted by worldwide. So we're using ICF the whole world to modify and approach the best way of how we can rehab an individual. And also Oxford 2021, they define rehab as the action of restoring someone to health or normal life through training and therapy after imprisonment, addiction, or illness. So I'm going to talk more a little bit about ICF. Now, as I've said, we have moved on from biomedical to biopsychosocial approaches. And in the ICF, we're looking at an individual. What is their health condition? What is the disorder, or what is the disease? Which I'm sure Patricia's touched on so many diseases. And then we're looking at that person, the body function. What are the impairments? What are the impairments in this body and the structures? How are they representing these impairments? And then we're looking at what are the limitations that are stopping this someone from doing an activity? What are the limitations? And then obviously we're looking at the participation. What restriction? Why are they restricted? With all these, we're looking at two different structures that can cause this. We're looking at environmental factors, and we're looking at personal factors. And Patricia's touched base on some of the environmental factors. And the environmental factors can include all sorts of things, environmental in your own home or environmental outside your home. And then we're looking at what are the personal factors. Is it an individual? Is that including psychosocial? Do we have mental health issues? Is there anything else personally that is affecting us apart from the condition affecting us, which has the condition has actually facilitated that? So we're looking at all that. Okay. The next slide, please. And again, I wouldn't have actually have gone away without including this. This is from the WCPT. The World Congress of Physiotherapy, they've actually established that 2021 will focus on rehab and long COVID. This is what we're battling with at the moment. Therefore, the focus for this year's World Physiotherapy Day is rehabilitation and long COVID, and the role of physiotherapists in the treatment and management of people affected by long COVID. A physiotherapist can help people living with long COVID as part of the rehabilitation program and make sure the exercise prescription that has been approached or prescribed with care to minimize the risk and to ensure the exercise programs are restorative and they do not make the person individual symptoms worse. Long COVID is different for everybody. A physiotherapist can help people manage their symptoms and work with them to support their recovery. Now, as we're talking about physiotherapy, it is not a physiotherapist alone cannot maximize someone's function. As Patricia has said about all other disciplines that are involved, And I would like to include the clinical psychologists as well. They play a big role in this. And not only clinical psychologists and personal assistants as well. And there are all other agencies as well that help to maximize the function of this person. Next slide, please. So we're coming on to community outlets. I've put Haringa there. It's just one of the barrels. But all these outlets are out there in the community, in the United Kingdom, as well as worldwide, even in Africa. The approach might be different, but they actually adapt within that same programs that we have presented. So that includes the Silverfit and the parks. We've got parks with open spaces. We've got free guided health walks. And we've got affordable leisure centers. Affordable, I'll come to that later. And we've got dance exercise and movement, gardening. And we've got home-based telephone call, telephone exercises. Somebody on the phone will be actually talking to you over the phone for those who can't use the visual exercise classes. And then within that group, we have got yoga, we've got Pilates, we've got Zumba, we've got badminton, tennis, Tai Chi, especially for the fallers, ballroom dancing, and breathe easy dancing. And then obviously the aqua aerobics and outdoor gyms. In the outdoor gyms, you have, for example, in the parks, you have bicycles, stationary bicycles, and you have cross trainer. They do have cross trainers sometimes in parks, and various things that are in parks, open spaces. Other agencies includes the Headway Center. And these are for clients who have sustained head injury. They have workshops and they have classes in that Headway Centers. And then also we've got the right to attend acute brain injuries unit. They have the right to attend if they want to. And then we've got so many events also with the right to attend and the acute brain injuries unit that support for vocational rehab. There are people who might want to go back to work. And also just personal projects. What are their hobbies like? So personal projects want to get back to what they do normally, that they enjoy. And also we've got good gym runners. These are supportive people with different tasks. And then we've got the Stroke Association, which obviously Patricia's talked quite a lot about stroke. And also these are My Stroke Guide and exercises and dancing, and Reach Association as well. Reach and Connect, these have got walking buddies and walking groups. And then we've got Spinal Cord Injuries Association. There's a charitable organization also that supports spinal cord injuries, wheelchair activities that go on. And these are organized with Aspire and also other charitable organizations within the spinal cord injuries. And also I've just put online NHS Fit for Free. There's a website on it, which anybody who actually is stuck or needs access, they can actually access this information. Next slide, please. Okay, we've talked about all that. Now we're looking at what are the difficulties that we face? What are the constraints to participation? We're looking at membership fees, lack of an individual finance resources. This is a big issue in the community, everywhere. Developing funding mechanism for NGOs. Disability access and specialist facilities. Trained, qualified staff in health and disabilities. Environment, climate, and lack of green space. So again, environment is a constraint as well. Some people in their homes, they've got very little space of which they cannot even exercise. Some of them are in a microenvironment. How do we solve that problem? How do we solve it if at all the environment is not conducive for them to do the exercises? And also the climate. Being United Kingdom is in Europe, the weather changes. Changes can be all seasons in one day. And you might find that inhibits people to do any exercises. And also their lack of green space. Not everybody has got big space outdoors. There's so many buildings across. There's so many factories. Where's the green space? And also we do face discrimination. A lot of discrimination. So it can be race, it can be gender, age, and it can be disability. And also appropriateness of an activity. You cannot just go to anybody and say, let's do this exercise. How appropriate is it for this individual to do the exercise? What will they benefit? Will it benefit them? What is it? How can we make it more appropriate for the majority of people to have an activity that will be of benefit to them? And then we've got social, culture factors. Some people might not want to go out for fear of gangs, for fear of being robbed, for fear of being just attacked. So they have to choose where they are, where will I go, that actually I'll be able to return home safely. And also they have to think about whom can I go out with? And also there's that peer pressure as well, that is pressing them about going out. And also we have the life stage, different stages of life. Some people might think, oh, I don't think I can do anything now. I'm just too old to do anything. I can't be bothered. So there's that life stage changes. How can we encourage that? How can we encourage that? Next slide, please. So what can be done during lockdown without facilities? Companionship, especially for people with low IT literacy, with reduced health outcomes and fear of contracting virus. So people might not want to go out because I'm going to go out, I'm going to meet all these people with no mask. I'm just so scared. I might just contract the virus again. And how can we improve on people with low IT literacy so that they can actually access themselves, the exercise program, through virtual or video? How can we do that? So we can upskill carers, because some people have carers with them all the time. We can upskill carers. We can increase the befriending service. We can also increase IT education and access to IT. And also multi-skilling allied health professionals and paramedics, because different people, it doesn't have to be a physio or OT or speech and language. Whoever goes in, they can actually get multi-skilled, so that even if they go and do maybe speech communication teaching or communication therapy, they can actually see that somebody has moved from one chair to another. That is an activity, that is a task. Or maybe they might want to do a OT work in the kitchen standing. That is a task. And also other professions like paramedics, they would go in and maybe check them. That is also part of therapists as well. And including use of charities with supporting services. For example, people can assist them with shopping and also health walks. And also making use of maybe next door neighbors as well. That can also be used. Some people share telephones with next door neighbors. That's to check on them if they're all right. Next slide, please. Okay. So my conclusion and recommendation is actually urge health promotion, which is a valuable concept, with allied health promotion, which they can utilize for and within rehab users. Validated research on specific rehabilitation intervention and programs for people with disabilities, including medical therapeutic assistive device and community-based rehabilitation, which is limited, and this can be encouraged worldwide. The government should develop and implement and monitor policies and regulatory bodies for the use of fitness and health and vocational industries for rehabilitation. Develop links between the educational services and community-based rehabilitation where they exist to maximize resources efficiently. And there are certain charitable organizations that have actually input of various activities. Let's use them, let's maximize while they are still there. Implementing recommendation across different sectors. For example, health, education, social protection, transport, housing, which is a big issue, including disabled persons organization. Next slide. And those are my few references from the Chartered Society of Physiotherapy and also Oxford 2021 and World Health Organization. And there's a link as well towards the end. Also the World Physio 2021. Next slide. So as you can say, this is peace. Let's promote peace. In that peace, let's encourage each other to race and participate. Let's not discriminate. Let's look at everything that is in that dove. Any questions?
Thank you so much, Milas. That was amazing. Another wonderful presentation. There is just so much in each of those presentations that, it's going to take a long time to unpick all of that. But, the ideas around personalization and making sure that we use all the facilities that are available. There are such a wide variety of facilities available. But what I'm going to do now, because we can come back to discussing some of those things, is to ask Marie to just discuss, because she comes with a perspective. She tells us that, she's had someone who has also been affected by long COVID. She's a professional herself. She's had to approach it from a professional perspective and a personal perspective. So I think that is, that's so insightful. So can I hand over to you, Marie, and listen to what you have to say?
Thank you. So I think during the pandemic all of your presentations were amazing. It talked about especially the things that are generally available, which the pandemic just ruined all of it essentially. So there wasn't the multidisciplinary teaming effect, because everybody was pushed into working in the acute area and really getting responsive within the acute areas with COVID. All of the community environments had stopped. A lot of the community services had less support, so there was less availability to get out in the community to provide the intensity of rehabilitation. So it was a really tough time for clinicians, because we knew we wanted to provide so much more for them and what they needed, but we were so limited. Having moved to a intensive rehabilitation unit right in the thick of the pandemic was also quite interesting. Because it meant that people weren't being connected with their family members as much as what they would have. So visiting had stopped, and all of that plays a massive part in that biopsychosocial aspect of getting that person to rehabilitate. My parents had COVID in the first wave of COVID, and I didn't even know what hospital he was in. It wasn't until, only because he went to the hospital that I was working at the time, that I was able to get in contact with some of the clinicians that work there. Had I have not been able to do that, I wouldn't have been able to communicate effectively to find out how he was, because it was a scary time for people. And it's since, thank God, he's okay. He's home now and he's recovering. And my mum was recovering at home. But it has changed. The COVID has absolutely changed so much. Our parents are much more reliant on their children now than they ever have been before. The long-term effects of the COVID, may it be physical or even bigger mentally, has played a huge part in there, because I think it was Milas, you talked about the fear of going out. And that is real. The fear is real, and just the feeling of this isn't ever going to improve because things are not the same as they used to be. But from my perspective, I mean, parents never listen to their children, doesn't matter how old they are. But from my perspective, when I gave advice to my parents about, you don't have to do everything in one go. You can pace yourself. You can do a little bit of a walk and set yourself some short-term goals and get to the end of the street and walk back and then see if you can make it a bit further. And it's those kind of approaches that they actually need, just a bit of encouragement, like you said as well, Patricia, to just keep going. But things have changed. They don't go to, they used to go to church. Everything's moved to Zoom. So they have had to get used to technology, which is also a good thing, I guess. So in order to remain connected in some sort of way, they've had to adapt as well. But it has been a tricky time. Now, the whole sort of moving into the community is absolutely the best place from a rehab point of view, because you can put everything, it's contextual. You're doing things in the environment that you actually live in. So it's the things that you do every day that make the biggest difference. But being able to work in a unit, I think it was the clinical psychologist that said this in a family meeting. It's a bit like going on that yellow brick road, and you've got to go down these journeys. So the acute hospital is absolutely appropriate at the time for your rehab at the very beginning, just to get you well so that you can get out of hospital. And then the next stage might be this intensity of rehab, because actually in the community, let's face it, you're not really going to get that anymore. So to get that intensity initially will then allow you to then have the confidence to maybe get back into that home environment in a better state, really. But the end state of that would be being at home and rehabbing the rest of your rehab at home. So we do need to, I think the healthcare system is really complex, and this is for clinicians that work within it, let alone if you don't. So it is really, really difficult to navigate your way around unless you know somebody that is able to do that for you or support you and facilitate it. But I can honestly say that, having been through it from a personal perspective, it was a rocky road. It definitely was. But I can see that where we as the younger generation play a part in supporting the older generation, and not just within your own family, but in the extended family, outside of your general friendship, even just making sure that you provide that support to anybody that you see that may be struggling.
Thank you, Marie, for that. That's really, really, really heartwarming. I think that one of the questions that I think I've got from just touching on the home kind of aspect to rehab is, with the challenges that exist in getting access to physios, are there any practical tips that you could probably suggest? I'll open the question to the floor in regards to home rehab for some of the listeners today.
Can I ask you to unmute yourselves? Yeah, if you're going to speak, and yeah, do share your thoughts.
I think the most important thing is that, first of all, the thing that people think about is, oh, the GP. I need to go to the GP. There are so many leaflets around the GP, and they only need a phone call with all these with the centers that I have actually mentioned. I think the whole UK, they should have centers. The GP also is another area that they can actually phone the GP. I'm not feeling well, or even if they don't have to feel well, I'm stuck at home. I've been here for a long time with COVID, and they can self-refer. They can also self-refer to community teams. They don't have to go to the GP. They can self-refer to the community for whatever problems that they're having. They don't have to sit, they can self-refer.
Well, can I follow up on that with you? Because there'll be a lot of listeners.
Yes.
I can't even get an appointment with my GP anyway, so even if I wanted to go to my GP, but how do people self-refer? If they can't get an appointment with their GP, you're out there in the community, how do they self-refer?
They refer themselves to the borough they live in. There's a community team. They have a community team, and they can pick up the phone and refer themselves. Each borough has got a community team.
Yeah, I think that's quite useful, Alice, if I might just pick up on that, because we underestimate the resources in our community, and we underestimate the community groups that exist in around us, and just making good use of library services. Now, during the lockdown, we couldn't necessarily go, but probably making phone calls and using, just trying to going online. I know that becoming more IT conversant was it pushed a lot of us out of our comfort zone. So using those online services, and I go back to the example that I gave earlier, where I work a lot in the community doing voluntary charitable work on people's health and well-being and exercise, and I've had done online exercise classes for groups, and these are elderly people who are diabetics, and they do the exercises, and we go through, and they follow, and they understand, and and we build resources within that. I can email things to them through the coordinator and so forth. So there are lots of ways, and we just have to be creative. And that's the whole thing about self-empowerment and self-care. You've got to find ways to self-care. Mm-hmm.
I think what you guys have also, I'm going to say, sorry, one of the things that you've demonstrated today is that this is it's a community aspect to it all. There are conditions like stroke and the like that we think of towards the latter part of people's lives, but also it can affect younger persons as well, particularly women of childbearing ages. And one of the questions I have here is relation to, again, that support, that help. Is there anything that we could suggest in regards to post-delivery for mothers who have undergone a C-section? Because obviously that's younger women, relatively younger women who need that help, need that rehabilitation, that support. Is there any particular sort of suggestions that you would be able to give for that particular example?
I think in terms of, obviously, when they are discharged from the acute, they would have an exercise program for post-cesarean section. Did I hear cesarean section? Yes.
That's correct, yeah.
Yeah. So they will have an exercise program which they will be given to practice when they start within the acute sector until when they go home. So that exercise program continues for weeks, and then it's guided on how much they can do. Otherwise, if they push it, they might just have prolapses, and we don't want that. So it's an exercise program, and again, they can do a self-referral, but they have to work with is it health visitors, women's health? Women's health, I think they have to work with women's health, because we don't want anything to go wrong. You have to work, because they have to know when is it that I can actually do more. Because don't forget, the abdominal muscles, the inner part of the abdominal muscles, they take long to heal. It can take maybe 1 year, the internal abdominal muscles. So they're told not to lift, to heavy lift or anything like that. The superficial ones, they heal quickly. Within 3 months, they'll say 3 months, 4 months, they heal. They're feeling fine, but you really have to be careful. So they are graded, the exercises are graded, and we have to liaise with the women's health on how we can progress from that. Does that answer the question?
That does. Thank you so much.
Can I add to that?
Please do. Please come in. Yeah.
Yeah,
so,
please.
So I agree. It's all about the aftercare support that they get from the health visitor. They will be there to guide the mother on what they should be doing and what they shouldn't really be doing. But I think a lot of it is about self-care and just making sure that you don't put pressure on yourself as well. Because I think as new mothers, you can put a lot of pressure on yourselves. You see other people, they get moving about really quickly, and actually you've got to do things in your own time. So it's also about being fair on yourself as well, and just enjoying the time that you have with your little one, and doing little things, because all of the things do in the day-to-day activities, and it's the same with any sort of rehabilitation. It's all the little things that you do every day. It's actually exercise in itself. So getting up and down the stairs, going into the kitchen and making yourself a drink, and you could be doing a little bit of movement and dancing to some music. That's all therapeutic and it's all exercise in itself. So just being vacuuming the carpet, just being gentle on yourself, and just remember that every activity is actually a part of rehabilitation and getting back to normality.
And can I also add that you can listen to your body as well. You can feel how your body feels and know when you've gone a little bit too far and where you can actually push yourself. And a lot of times when you're discharged from hospital, you do get, as Marlis mentioned, like a booklet or leaflet or handout or exercise sheet that you can refer to. And usually there's a contact number or an email on address and all the information that you need to contact people who, if you need to. Yeah.
Excellent. And one of the things that I come across when in other spheres of the work I do, people say physios are very good at giving leaflets with exercises on, but people don't always have the motivation to follow through. And they say what do? They just don't do them. Either the exercises have to be too boring or they just haven't got the motivation. How do you advise? What would you say to people like that?
Well, I often get them to focus on what they enjoy doing, because if they enjoy doing it, they will do it. But also going back to that whole contextual thing, if they can put it into context, if you give them knee lifts, they don't understand what you're doing it for, or if you give them squatting, they don't understand what that's about. But if you say to them, I want you to think about how many times you do a sit to stand, or I want you to walk up and down a flight of stairs, that makes it much more of a functional activity, to the point where they don't actually realize that they're doing exercises. And that's what's important. They need to be able to move in a way that they don't really, because some people didn't used to go to the gym before, they didn't used to do exercise, it was not natural to them. So it's all about making that movement as functional as possible.
That's true.
And I also think that it's about getting them to set their goals. And as physios, we do a lot of joint goal setting. So it's not about what I want as a physio or what you want as a physio, but what does the patient want? What do you want to do? Where do you see yourself? And when you can work with the patient that way, then it becomes their goal, and it becomes their effort, and they are motivated, and you encourage them along the way as well.
Yeah.
Fantastic. And I just want to change tact a little bit here, because I pick it up from Milo's presentation, talking about health promotion. That's the real reason why we're here. We're talking about rehabilitation, and I think that's fantastic that we've been able to entertain that as a discussion point today. I'm really interested in how you all came into your roles as rehabilitation experts, because I think that is, I can hear the passion in the delivery of presentations and talking about rehabilitation. So to just let me know, let the audience know how it is that you came into your particular positions, if you will.
Who wants to kick off? You want to go first? We can all have a little say. Go on, Patricia, off you go.
Okay. Well, I always enjoyed working with people. I've always been interested in health and healing, and I always felt that I wanted to work with people. I wanted to have that hands-on effect and to see people get better. I know that there are other, that's a very general term. But I think for me, working, what really motivated me was, I think when I went into a hospital and I observed, when I was trying to look, what's the career I wanted to develop, and I observed and I saw how physios are working and the relationship that they develop with their clients, and how much your rehab and how successful you can be depends so much on that rapport, on that relationship, being able to stimulate and encourage and motivate. And it's a relationship. And when you look, for me, being able to see, for instance, somebody who's had a stroke, and I've worked a lot with stroke patients for more than 30 years. And when I look and see that somebody who was not able to walk, so dejected, so so sad. So it's as if their whole life has come to an end. And somebody comes and say, okay, just take a step. And you do a bit of stretching and passive movement and stimulate the nerves and do whatever you have to do the functional weight bearing exercises and so forth. And then eventually they can make a step, just to see that happiness in their eyes. And that, it really, for me, it really just makes such a difference. So, it motivates me as well. So yeah, it's about helping people.
Yeah, it is indeed. It is about helping people, and also a job satisfaction as well. Job satisfaction as well. I mean, I am very passionate about my role, and there are times where it has been like, oh my goodness, very frustrating. There are some conditions that can be very frustrating because you're not going anywhere. But just you being there, it motivates them. It motivates them, and they want you to continue doing that. Now, there's a danger in that, because if they see you all the time, they're not going to empower themselves to do things on their own. So it's a question of working together. It's a partnership that you develop with a person. You develop that partnership. You're seeing the journey together. Where you will fail, we sit back and let's see where we've gone wrong. Let's go forward. There's no right or wrong in the management of these clients. It's just so long as they reach their goal. If they haven't reached their goal, at least they've reached somewhere where they can function. You've left them somewhere where they can function. They might not even be able to walk. A spinal cord injury patient might not be able to walk. They do say they can walk, but practically, you've seen spinal cord injuries, clients doing sport activities in their wheelchair. All those are job satisfaction. They're happy because you've made them function in a different way. So it is partnership, and it's really very rewarding. Really rewarding.
Marie, what motivated you to develop health promotion and be in physio?
So I think it started ages like school, secondary school. I've always thought I want to be a physiotherapist, even really not knowing that much about physio. I was like, this is what I want to do. But just to confirm that, during your 2-week placements at secondary school, I managed to get a really good placement in a rehabilitation hospital. So I had the opportunity to work with physios, OTs, speech and language therapists, and my sister didn't know what I've got a twin sister, by the way. She didn't know what she wanted to do, and actually it was me that introduced her to occupational therapy. So she does occupational therapy in neuro rehab as well. So and my mum was a nurse. She's actually from the Windrush generation. She was a nurse. So I knew healthcare was something that I wanted to do. And I've also got an older sister who's a sonographer. So all the girls were into something to do with health, but physio was absolutely the thing that I wanted to do. And then I kept an open mind in terms of which part of physio, because as you well know, physio is very broad. You can do so many things. You can do respiratory, musculoskeletal, you can do oncology rehab, neuro. There's so much that it's so vast. And that's another reason that I thought this is really interesting for me. But I I was drawn towards or magnetized towards neuro rehab. And again, I'd probably echo everything that everybody else has said around the fact that it's the littlest things that you manage to do for these individuals that makes such a huge difference to them, and it has a huge impact on their life afterwards. All the secondary prevention information that you can provide for them as well, really, it's so satisfying to see them. It's the journey that they've come from to where they are when you're seeing them, rather than actually looking at, yes, that is their goal, their long-term goal or their short-term goal. It's more about look where you've come from to where you are now, and for me that is the most satisfying thing about neuro rehab.
I think it hit the nail on the head. I think any physio, well, I think all the physios that I speak to, it's the ordinary things, it's a function. Just seeing people do things that they find terribly difficult sometimes. And as you say, the journey, it's not always going to get to the end goal that they set. You set goals and you keep changing them. But that journey is so important with individuals, isn't it? Anyway, I won't dwell on that too much because I know are there any more questions?
Yeah, there are. So, I mean, thank you very much for sharing that. Before I move on to the next question, just again, thank you for tuning into the Jamaica Diaspora UK Health and Wellbeing Arm discussion on rehabilitation this evening. We've got great panelists talking about their expert kind of opinions on their field of interest here. I've got a loaded question here, which is everyone's entitled to rehab, but does the NHS have the capacity to give rehab to everyone who wants it, or do we need more passionate experts like yourself in the field? Please let me know. What do you think?
We are never enough. We're never enough. Yeah, there is always a shortfall of, it just shows then that obviously with the people now living longer, we're going to need more therapists, and also people living longer, they have to learn, empower themselves, that they can do other activities out there without relying on the therapist. True, get guidance from the therapist, but we have to empower ourselves as well.
What are the types of roles to get into rehabilitation? I mean, we've talked a bit briefly about getting the experience, at school, etc. But how is it that you get into it? What's the route?
So normally, most schools, most educational establishments will give a broad-based experience to all students. So all aspects of physiotherapy, students will be exposed to the main ones. So students will have a taster of neurology, they'll have a taste of respiratory aspects, they'll have a taste of pediatrics, they may have a taste of obstetrics. And then when people have those taster sessions and have those placement experiences, they get a feel of where they want to be. I don't know, we can ask our panelists.
Yes, I mean, students do get through their studies at university. As you know, I lecture at the University of East London. I've taught and to teach physiotherapy students, and they go on placements that allow them to get a broad experience of the main areas: musculoskeletal, orthopedic, neuro, respiratory, and community, sort of the broad areas. And some, if they're lucky, might get a pediatric placement and so forth. But a lot of times when students actually graduate and begin to work, they decide what area of specialty they actually do want to do some more continuing professional development work, or even further studies, or even masters and beyond. So a lot depends on where their interests lies.
Can I add to that? So my route was slightly different. So although I always knew I wanted to be a physiotherapist, I initially went and completed a degree in applied sciences, which was the days of when you could do majors and minors and combined and that sort of thing. So I did a vocational qualification. Well, it wasn't something that I could use. It was human biology and exercise physiology, but it did set me up for the basics of what I needed to then do the physiotherapy degree. So I had decided, after not being able to actually get a job in physio because I couldn't get onto the course, that I would work as a physio assistant for a year. And so I worked as a physio assistant in with a team of physios only, but I managed to do community work. I managed to work with the musculoskeletal therapists, and I also managed to work with the community neurotherapists as well. And I got a huge insight into what the role really required. And I think that really did help me, and also really further inspired me to do physiotherapy afterwards. So then I applied for the course and managed to get to the university that Mel Stewart taught at, which is how we met. And it was a great experience. I know what I might add is that I think from an African Caribbean community, there isn't enough of us doing physiotherapy as a qualification. Absolutely. And actually having the faces, you won't be what you can't see, and actually to actually see that there's other people that represent you is so important, because you wouldn't think about some of the other people that because I do Inspire the Future program. So I go into primary schools, they don't even know what physiotherapy is because they're only little, but also they wouldn't even probably expect someone with the face like mine to even be doing something like that, because you just don't see it that often. And I think it helps to inspire those people that didn't even recognize that that was something that they could do. I wouldn't consider myself to be hugely academic, and so I always say to those young people, if I can do it, so can you. You've just got to apply yourself. So and I think it's really important with our demographical population as well. So we are able to relate to our people more so we can understand them a little bit more. So it's so important that we try and promote, physiotherapy is a good profession to be in, and let's get more people on this course.
Yes, absolutely. I agree with that 100%, Marie, because physiotherapy is predominantly white female, and not even, well, I don't know what the demographics now, probably Mel might be able to say more about that in terms of the ratio between men and women. But we do know that we do need to have more representation of the of African Caribbean professionals in physiotherapy, because it's all about the cultural appropriateness of some of the exercise and some of the things we do, how we share, how we talk, how we communicate, and people understand that, and people relate to that, and you're able to engender and motivate because you're talking the same language. So I think that is so important.
Yes,
very, very important indeed. And in fact, I'll just touch on that very briefly, because I think David will recall we were looking at NICE guidelines for stroke rehabilitation some time ago. We were looking at informing the NICE guidelines, because when I searched the literature as to how they were approaching rehabilitation in the community, and looking particularly at the African Caribbean community, the church plays a huge part in how it supports individuals. And I did see, and there were 2 pieces of literature I found that gave evidence to that. And that's something I think that is readily, with the people would naturally think about the church and the rehabilitation and the context in which Black people rehabilitate. So it's so important, so important.
Fantastic. Thank you so much. I'm a little bit sad at this moment in time, because we've only got 6 minutes left and I don't know where the time has gone. But I think it's when you are having fun, time does fly by. The old adage is there. So I'm just going to ask you to wrap up with your final thoughts on rehabilitation, tonight's event, and any closing statements that you each would like to sort of impart in terms of wise words of wisdom. So if you want to start there for us, Patricia, that'd be great.
Okay, well, what I would say is that empower yourself. Know that you're capable, you're able, and when you come from a point of being at peace and enjoying the fact that you can, regardless of what's happened, you have the potential. You have the potential to realize your goals and your aspiration, your dreams, regardless of what disability you might face, and that you can do that. And with the help of the physiotherapist who works alongside you, then you can achieve whatever you may. So never give up.
Never give up, indeed, and try not to have a no in your dictionary. Try to have a positive approach all the time. Try to do that. You can reach your goal, and use the physiotherapist as much as you can. That's why they're there. Use them. So I think this is my final request, to say that go forward, don't be afraid, go out, do what you enjoy to do most and best. Just continue empowering yourself, as Patricia said.
So from adding on to that, I would again obviously echo everything that everybody's already said, but from the very beginning, when we talked about rehabilitation, and we talked about the fact that it's not just about physio, we are physios, but it's not just about physios, and it's drawing upon and understanding the fact that there's so many other professional groups that really make up that rehabilitation model. And by drawing on dietitians, we can, from a
Yeah.
diabetic point of view,
Yeah.
but
Yeah.
also from a point of view of if you've got long COVID as well,
Yeah.
just getting the right nutritional content in so that you can exercise, because without the right nutritional content, you probably couldn't physically do anything. The occupational therapists play a major role because they are the ones that support the functional activities that you might then have the ideas for your exercise program to then formulate what will happen in the home environment. Speech and language therapy as well, from a swallowing point of view. Without being able to swallow, you can't eat. So from a nutritional content, so everything has so much interconnections. And I think it was Miley's mentioned the psychologist, clinical psychologist, so important. So in the best will in the world, you do try to provide that emotional support. But if you're not the professional, that's okay. You can provide what you can, but actually drawing upon those clinical psychologists, which are very far and few between, I might add, is really, really, really useful. So many of the people, the nurses, everybody, they play a huge part in making sure that the rehab is successful.
And don't underestimate the role of the family.
Yes,
Family,
yes,
friends,
right.
neighbors, community. The family is key to rehabilitation.
Yes. My 4-year-old played a huge part for my dad in terms of motivating. So that intergenerational working as well.
Wonderful.
Hopefully we can start to get that back in place, because COVID stopped all that as well, didn't it?
Yeah.
That's intergenerational wealth and health.
Generational, that's where I'm coming from. You know what? As a physio, you look at a mountain, you may never climb that mountain, or will take forever to get there, but you can take a step, and each step takes you further. Step at a time. Never try and bite off more than you can chew.
That's right.
Yeah. Yeah.
I just want to thank you. I'm going to hand back to David, but I'm just always bowled over by my colleagues, because the enthusiasm you get is very catchy. And I know that we support each other as well as our patients. So thank you very much.
You're welcome.
You're welcome. Thank you for having us.
Thank you for having us. Thank you very much.
Thank you.
You're muted.
Ladies and gentlemen, thank you. Sorry about that. Ladies and gentlemen, I'm your host, Dr. David Burton, Chair of the Health and Wellbeing Arm, and I'm just so delighted to have had such passionate guests. I think most passionate guests I have had on this platform, with no disrespect to previous people who have been on the platform, but thank you so much for coming on this evening. In no particular order, we have had Marie Adams, we've had Dr. Patricia Smith, Dr. Miles Ruth Mwanza, and Dr. Melrose Stewart this evening, talking about rehabilitation and making a difference in people's lives. I think that's the key that I've taken from today. Making a difference through small changes, you can make big changes in people's lives, and that's the take-home message from me. And I'm just delighted to have had you on this evening. I wish I could have given more time to you, and I'm sure we can. This has been a great week. We've had a windrush week. Talking about the passage of people, of generations gone by, and we are all trying to make those changes accordingly across this part of the world, but also sharing across the nation. So thank you very much for being here this evening. I want to give you all a round of applause for being here. Thank you so much.
Thank you very much.
And I look forward to sharing George's again.
Thank you.
Good evening.
Thank you.
And thanks to Jamaican Diaspora UK, and also thanks to Victoria Mutual for sponsoring this event tonight again. Thank you.
Thank you.
Have a good night.